Thank you very much for that kind introduction. Good afternoon, friends and colleagues from all around the world. It's great to be here. Thank you, Nikolai, for inviting me to give this talk at this fantastic meeting. It's a big pleasure to be able to celebrate the 100th anniversary of the discovery of glucagon together with so many fine researchers. So I think it's very clear that both we as glucagon researchers and also glucagon as a molecule has been in the shade of insulin and insulin researchers over the last many decades. Just if you look up insulin on PubMed, there is like 500,000 hits, whereas with glucagon, there's only 1/10 of the hits in terms of PubMed hits. And also, if you think about that, insulin was discovered 100 years ago last year, and the many celebrations around the world celebrating insulin as a molecule and as a savior of many patients around the world. At least I have not been invited to any glucagon 100-year anniversaries except for this one, and I've not heard of others. So I really think that we should also applaud Nikolai, as many of the other speakers have suggested, for transforming this ugly glucagon duckling into one of the beautiful swans flying in the air up there. Perhaps this is Nikolai, perhaps this is glucagon, but I'm pretty sure that some meetings like this will help move the duckling up into the air among brothers up there. So this is the agenda I've put together for the next 25 minutes or so. I thought that it would be nice to take a historical view on glucagon and its role in the pathophysiology of type 2 diabetes. And secondly, I would also like to try to understand the pathophysiological background of the hyperglucagonemic state of type 2 diabetes. And lastly, I will try to allude to the role of hyperglucagonaemia in the type 2 diabetic hyperglycaemia. So these are the three themes for this talk. But let's start out with taking a historical view on glucagon and hyperglucagonemia in type 2 diabetes. Some of the first notions around hyperglucagonemia or glucagon contributing to the diabetic state came from Spain just after Second World War, where these Spaniards took out the pancreas from an alloxan-induced diabetic dog. So that means that this pancreas pretty much had destroyed beta cells, but when they took out the pancreas from the duck, it actually ameliorated its diabetes, suggesting that something in the pancreas, in this case alpha cells, would probably worsen its diabetic condition. Just the years after, Helmut Ferner from Hamburg in Germany, he showed that the ratio of alpha cells and beta cells in diabetic patients was shifted towards more alpha cells as compared to beta cells. Maybe that's not a surprise, but back then it was a notion fueling that glucagon and alpha cells may play a role in diabetes. And then using the first glucagon RIA, Roger Unger and his colleagues demonstrated that, first of all, fasting hyperglucagonemia in both juvenile diabetes and also adult type diabetes, that is type 1 and type 2 diabetes nowadays. And both these types of diabetes, they were characterized by what he called relative hyperglucagonemia, at least when glucose levels were normalized to healthy controls. Also, he showed that both these types of diabetes were characterized by an increased response to arginine infusion, meaning that these patients, they have hyperreactive alpha cells to infusion of arginine. Then shortly after that, these people from Belfast, Buchanan and McCarroll, they showed that by giving a carbohydrate-rich meal to patients with non-insulin deficient diabetes, that's type 2 diabetes, and insulin deficient diabetes, actually resulted in the type 2 diabetes patients a lack of suppression of glucagon, whereas the insulin-deficient diabetes or type 1 patients, they actually responded with a paradoxical increase in glucagon, also suggesting that glucagon may be involved in the pathophysiology of these forms of diabetes. Let's just return to Roger Unger for a minute, because it's impossible to read glucagon literature about type 2 diabetes and also type 1 diabetes without stumbling across Roger Unger's many works. This is just the work that I just talked to from 1970, showing that patients with type 1 and type 2 diabetes, they are characterized by relative fasting hyperglucagonaemia. But reading the literature, you will find hundreds of papers from Roger Unger alluding to the involvement of glucagon in type 2 diabetes and type 1 diabetes pathophysiology. Probably one of the most important and probably one of the most well-known one is this one describing the bihormonal hypothesis together with the Italian Lelio Orci. He did all his research from Geneva, but he was originally an Italian. And together they published this paper in 1975 describing that it's impossible to have diabetes without glucagon. And this paper relies on 3 lines of evidence. Firstly, that you cannot have hyper or endogenous hyperglycemia or diabetes without or in the absence of glucagon. Secondly, when you use somatostatin to suppress both insulin and glucagon, you will have normal glucose levels unless you will only have hyperglycemia if you restore glucagon levels to normal by giving exogenous glucagon. And the third line of evidence is that if you have somatostatin-induced glucagon suppression, that can reduce glycemia in diabetic people and Alexian diabetic dogs. So that means that in order to have diabetes, you must have glucagon on board. Actually, this heavily cited hypothesis paper only have one figure in it. So in a way, it's a case report about a dog. So this dog was operated or was undergoing a total pancreatectomy, and what Lelio Orci and Roger Unger did was that they gave it a somatostatin infusion during the pancreatectomy. And what you can see here is that they take the pancreas out during the somatostatin infusion. Nothing happens with the plasma glucose levels. But when the somatostatin infusion stops, allowing glucagon levels in the below panel to increase, that is when you see the glucose levels also increasing. So this is the foundation of the bihormonal hypothesis published by Roger Unger and Lelio Orci. I think if you have either written about or if you have read about glucagon and type 2 diabetes, you have probably seen a reference to this work, Gerald Reeven's work from 1987, showing for the first time that glucagon levels in the fasted state and throughout the day, they are elevated in patients with type 2 diabetes compared to healthy controls. And here you can see from the figures, it goes for both non-obese patient with type 2 diabetes compared to non-obese controls, but also for perhaps even more clearly from obese patient with type 2 diabetes. So this paper really shows that patients with type 2 diabetes, they are indeed characterized by elevated glucagon levels. If you take a look at it in kind of patients from this millennium. You can see here, these are 10 patients with type 2 diabetes compared to 10 healthy controls, shown here after a meal test, where it clearly can see the hyperglycemic state of these patients, both in terms of fasting and postprandial hyperglycemia. This is what happens to insulin during a meal test like that. So not a really big difference, but we know, of course, that compared to the glucose levels, these patients are, of course, characterized by both postprandial hypoinsulinemia, and also, of course, insulin resistance, contributing to the hyperglycemic state of these patients. But the real big difference is, in fact, in terms of glucagon. You can see a clearly hyperglucagonemic state in the fasting state, but also postprandially, these patients respond with grossly exaggerated plasma glucagon levels. So this is a mixed meal response. So that was kind of some historical notes about glucagon in type 2 diabetes. Now I would like to move into the pathophysiological background for the hyperglucagonemic state of type 2 diabetes. Here's what happens when you give an OGTT, a 75-gram OGTT, to patients with type 2 diabetes and body mass index matched healthy controls. So you can see that the healthy controls shown in the bottom of this graph, they suppress their glucagon levels to the all-glucose stimulus, whereas the patient with type 2 diabetes, first of all, again, are characterized by fasting hyperglucagonemia, and then they respond with this paradoxical increase in glucagon levels and a delayed suppression of glucagon levels. The traditional explanations for these characteristics curves in the type 2 diabetes has been an alpha cell resistance to the glucagon suppressive effect of both glucose and insulin, combined with the hypoinsulinemia of type 2 diabetes. But let's take a look at this 75% increase in fasting plasma glucagon in type 2 diabetes. And let's try and look at if it could be liver fat content that actually determines this fasting hyperglucagonemia. And I would also like to share with you some data, at least, suggesting that this postprandial or post-OGTT increase in glucagon levels and its delayed suppression may actually be dependent on some gut factors secreted from the small intestinal tract. But let's start out with the fasting hyperglucagonemia. Actually, we came onto the idea that the liver may be involved in this because of this study from 2012, where we compared obese patients with type 2 diabetes to lean patients with type 2 diabetes and obese non-diabetic healthy controls to lean healthy controls with complete normal glucose tolerance. So what you see here are basically glucagon responses to either an all glucose tolerance test or an IV glucose infusion administered to mimic the glucose concentrations during the all test. And you can see they all suppress glucagon to some extent in response to these glucose stimuli, but what is very clear from this study is that it's only the obese patient with type 2 diabetes, not the lean patient with type 2 diabetes, who are characterized by fasting hyperglucagonemia. And the same goes for the obese versus the lean non-diabetic people. So it seems like that this fasting hyperglucagonemia is not directly related to diabetes, but more to obesity. And then, as we all know, that the liver is the main target for glucagon, Nikolai and Anders Juncker, they also investigated fasting glucagon levels in patients with type 2 diabetes with and without NAFLD, non-alcoholic fatty liver disease, and matched healthy control. So these patients, they have the same body mass indexes. The only difference is the liver fat content. And you can clearly see here that independently of the diabetic state, patients with NAFLD, they have elevated fasting glucagon levels, and they go hand in hand with fasting total amino acid levels. And in fact, when we looked at the individual amino acid levels, we could see that these two amino acids known for being glucagonotropic, they were the ones who were particularly up or highest in concentration in the patients with NAFLD. And some of those data and other human data combined with a lot of data from these four very important papers. I think people who are on these papers are in the room. We've heard a great talk from Daniel Dean about the paper from Alvin Powers' group at Vanderbilt University in Nashville, but also the papers about from Jesper Gromada from his time in Regeneron was very important, and also the paper from Daniel Drucker's group, stating that if you block glucagon signaling in the liver, something happens in the pancreatic alpha alpha cells, meaning that they proliferate and you see hyperplasia, and they also start to secrete more glucagon. So on that back of that notion, we kind of sat down together with Jens and Nikolai and other people and developed this idea that we call the liver alpha cell axis. So basically it states, we have seen this many times before today, so I'll not go through it in details, but this idea that the liver fat content in the liver actually makes the liver more resistant to the glucagon's effect on ureagenesis. It's reduced, increases the circulating amino acids because amino acid turnover is reduced in the liver, and the increased amino acids is a signal to the pancreatic alpha cells to secrete glucagon, and with